So I'll be speaking to you about gastrointestinal dysmotility and more specifically autoimmune gastroparesis. These are the disclosure slides, and I have nothing to disclose. These are the learning outcomes that I hope I will help you to achieve today. And this is your CME link if you need CME. And then I'd like to start with this slide. I like this slide because it reminds us of the complexity and the elegance of the enteric nervous system. And it also reminds us that the GI tract is, for all intensive purposes, a neurologic organ. There's a lot of neurology that goes on there, and there are actually more neurons in the length of the gastrointestinal tract than there are in the spinal cord. So this is the outline that I'll be using for my talk today. So in looking at patients with common GI symptoms that people with dysmotility present with, you can see that abdominal bloating, distension, pain, and nausea are very, very common symptoms. The problem being that if I superimposed on this slide a slide that was titled Common GI Symptoms in Patients with IBS, the symptoms would overlap quite a bit. And the point I'd like to make is that you really cannot get a good handle on somebody's motility or lack of motility based on their symptoms alone. Symptoms are not a good predictor of motility. When I see somebody with a suspected motility disorder, I think of these guys as the usual suspects. And then in a study that was done in 2001 by Dr. Richard McCollum, where he looked at a large cohort of patients who were presenting to a tertiary referral center with gastroparesis, the most common cause was idiopathic, followed by diabetes, and then post-surgical. What you don't see on this list is autoimmune gastrointestinal disorder. There's no autoimmune gastroparesis on this list, and I think that that's because in 2001 we really weren't cognizant of that or accepting that as a clinical entity. So my suspicion is this idiopathic group, this large idiopathic group, is probably made up of a combination of post-viral and autoimmune and maybe a few other things. I think they're there, I just think we weren't recognizing them. And then I just wanted to say a few words about this entity of chronic intestinal pseudoobstruction. So gastroparesis, most people know what gastroparesis is. The stomach is not emptying. Chronic intestinal pseudoobstruction, patients will have radiographic signs and symptoms that suggest to you that there's a mechanical obstruction, but no mechanical obstruction will be present. And the symptoms can be continuous or they can be intermittent. And the abnormal motility can involve any area or all portions of the GI tract. This is the x-ray of a patient of mine who has chronic intestinal pseudoobstruction. And as you can see here, he has had a laparotomy, and in fact he had more than one laparotomy. The first was performed outside of the Mayo Clinic, and then when he came to the Mayo Clinic, his CT scan looked so convincing for a mechanical obstruction that our surgeons felt comfortable taking him to the OR again for an exploration. He did not have a mechanical obstruction, but fortunately, at the time of the laparotomy, they were able to get a full thickness biopsy that provided us with some useful information, and he ended up having a lymphocytic infiltrate that did respond to treatment with methylprednisolone. So one of the points I want to make here is that You may end up taking somebody to laparotomy that does not need a laparotomy. If you do take them to laparotomy and they don't need a laparotomy, at least take advantage of the fact that you're there and try to get a full thickness biopsy, because that may help you with a clue as to what the etiology of the underlying pseudoobstruction is. So evaluation should include a careful history about the symptom onset, their character and duration, orthostatic symptoms, heat intolerance, visual changes, urinary symptoms, sexual dysfunction, as Dr. Sandroni said this morning, and also family history. Some people will have a family history of dysmotility, and it can be quite helpful to discern that. And then a very careful review of patients' medications, both over-the-counter medications and supplements. And specifically, nowadays, I do ask all my patients who present with upper gut symptoms of abdominal pain and vomiting about cannabis use and synthetic cannabis, because there is an entity called cannabinoid-induced hyperemesis that can present with severe abdominal pain and intractable vomiting. And if you don't ask about it, many patients won't volunteer that information, but it's really, really crucial to know so that they get the appropriate treatment. So in selection of the appropriate tests, to some degree they're guided by symptoms, but I do have an algorithm that I use to help me in evaluating these patients. So pretty much everybody gets an upper endoscopy with upper GI symptoms and abdominal imaging, which usually might include a CT scan and some cursory laboratory tests. If this gives me my answer, then I'm done and I treat it. If it doesn't give me my answer, then I move on to a transit evaluation, which, depending on their symptoms, might be limited to the stomach, or it might be a full gut transit evaluation. If the transit of the stomach or the small bowel is abnormal and there's no underlying disorder that I've identified, then I would do an upper gastrointestinal manometry, which I'll talk a little bit more about, and this will allow me to divide the problems into a neuropathic problem, a myopathic problem, or a mechanical obstruction that's been missed. With the high quality of our CT scans, this really doesn't happen anymore. It was happening in the definitely in the 80s and early 90s, but it's really very unheard of now. This is a typo, and instead of ANNA, it should say autoimmune panel here. So as far as assessing gastric emptying, the gold standard is a radionucleotide gastric emptying scan. And it's a test that's readily available. It's something that's not hard to do, but it's not done with the ideal protocol in a lot of institutions. It's very, very important that the meal is standardized. And this picture is to remind us of what the meal is. It's basically eggs, toast, or eggs or egg beaters, toast with jam and water. And the meal has a certain caloric content. I think it's 460 calories. In any event, that standard meal is eaten over a standard period of time, and then scanning is performed at 1, 2, and 4 hours. It's very, very important that you perform the scanning at 1, 2, and 4 hours and don't extrapolate the data, because if you scan for just 90 minutes and extrapolate the data, you're going to get a curve that's not right. It's not, there's this lag phase with a solid meal, and so you really have to scan people out to 4 hours. So that's a pitfall that I see in patients who've been referred to me from elsewhere with gastroparesis. The other pitfall that I see is that people are given a semi-solid meal, which might be an oatmeal or a porridge or very occasionally something like an Ensure drink, and those are not an adequate test of gastric emptying. So it has to be the standardized meal, and it has to be for 4 hours. And the patient doesn't have to be on the scanner for the whole 4 hours, but they need to have a picture taken at 2 hours and 4 hours so they can go and come back, and that's how we do it in our institution. At Mayo, we are also able to use this scintigraphy, this meal, to follow the transit of the meal through the small intestine. And that's not available everywhere, but what might be available in your community is the pill camera that everybody's been talking about lately. The pill camera can allow an assessment of emptying, and it's fairly accurate. It may underestimate gastric emptying a little bit, but it's very good for small bowel and colonic transit, and as I said, I think it's going to become more and more available. So with our studies, this is the kind of image we get, and this is the stomach, 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 and then this is the tracer going into the small bowel, and then down here is the colon, and this is the colon. And basically, by drawing these little curves around where the tracer is, we come up with a geometric center, which is a weighted average to tell us whether the transit is normal or not. So if the transit is normal, you're done. But if the transit is not normal, then the next test you might consider is a gastroduodenal manometry. And this test involves an endoscopic placement of a tube that comes across the pylorus and then down into the proximal small bowel. There are 5 sensors that bridge the pyloric region, and then there are 3 more distally. And the patient is observed for 6 hours. There's a fasting part of the study, and then they're fed a meal, and we see what happens to the contractility in the gut after they eat. And this is not something you need to remember. You just need to remember that there is a normal fed pattern and there's a normal fasting pattern. And the tracers that you get look something like this. So this is a normal fasting pattern, and this is a normal fed pattern. And there are also patterns that are very characteristic of disease. So in a myopathy like systemic sclerosis, you'll see very low amplitude contractions throughout. In a classic neuropathy, diabetes is the one that we have here, there's just kind of chaotic, disorganized activity. And so by that test, it's a long test, it's a 6-hour test for the patient, but it can often give us very helpful information. The other thing I always think about when I'm seeing a patient with possible GI dysmotility is about their medications and side effects of medications. And opioids are really, really bad for the gut. And unfortunately, people who have pain are often on opioids. So I talk about that, and I will never test somebody on opioids, because if you're doing these tests with patients on opioids slow everything down, and the tests are really not useful or interpretable. So if your patient is on opioids and you're considering doing a gastric emptying test or any of these transit studies, the opioids should be gone for at least 72 hours, or you're wasting the patient's time. The same with medications that have a strong anticholinergic effect. And the GLP-1 analogs, which are used for diabetes, can delay gastric emptying. And then the other thing is, I already talked about, I think about mechanical obstruction. In patients with a lot of bloating and diarrhea, in addition to their nausea, I think about bacterial overgrowth. And we can easily test for that with a breath test, and that's something that's done in the office with either a glucose drink in non-diabetics or a lactulose drink in the diabetic patient. And we plot a graph based on their breath hydrogen excretion, and we can tell if they have bacterial overgrowth or not. I generally tend not to treat people empirically for bacterial overgrowth, and the reason I don't is because we've all experienced the placebo response, and if you're treating somebody empirically and they get a little bit better, then they're going to want to have antibiotics again, and I just like to know where I started from and if I'm going down the right road, if I'm going to commit somebody to recurrent courses of antibiotics. And then constipation. You always need to think about constipation. It's remarkable to me in my practice how many patients will come and visit with me because they're really nauseated and distended and they're having cramping abdominal pain, but they're not recognizing that there is a problem with their lower GI tract, and they may be going 5 or 7 or 10 days without a bowel movement. And this is one such patient of mine. During this, she's actually having a SITS marker study here to evaluate her colonic transit, but there's a tremendous amount of stool in her right colon and a fair amount of stool in her left colon, and you can imagine that she feels bloated and distended and nauseated. So always think about constipation. And now I'm going to change gears a little bit and talk more specifically about autoimmune gastrointestinal dysmotility. So this is an organ manifestation of autoimmune dysautonomia. I do believe it's under-recognized, as I showed you on my second slide. People weren't really thinking about it at all 15 years ago, and now we're thinking about it. I think in our tertiary referral centers, we've seen patients with this, but not everybody is on board and not everybody is aware of this. The incidence and prevalence is unknown. Looking at the case reports, there does seem to be a predominance of females. It can be idiopathic or paraneoplastic. For our purposes, we're going to talk more about the idiopathic variety. Paraneoplastic, it can be associated with cancers, usually a thymoma or a lung cancer. And usually that's pretty obvious because those patients present with a very, very acute presentation. They have dramatic weight loss, and they're usually older patients, so you should be thinking about cancer. Any region of the GI tract can be affected, and the symptoms can be variable based on the part of the GI tract that's affected. They can present acutely, subacutely, or insidiously, so I'd think weeks, months, or insidious, I'd think months to years. And the neurologic manifestations can be pronounced, or they can be very subtle. So the clinical features that raise my suspicion for an autoimmune GI disorder: detection of neural antibodies associated with a presentation of dysmotility and an abnormal transit study, symptoms that could warrant a trial of immunotherapy would include severe symptoms that fail to respond to symptomatic medications, again, in the setting of objective findings, and objective evidence of extraintestinal autonomic dysfunction, such as thermoregulatory sweat testing or autonomic reflex screening. A personal or a family history of autoimmunity, or serologic evidence of extraneurologic autoimmunity. And then again, for the neoplastic factors, a history of smoking would be a red flag. So what does this antibody profile look like? So these are the antibodies that we test for at Mayo when we are concerned about an autoimmune GI motility disorder. And as Dr. Sandroni said this morning, this ganglionic alpha-3 acetylcholine receptor antibody is one that we see more commonly in people with GI tract involvement. The DPPX antibody against the voltage-gated potassium channel is one of the newer ones described, and it's different from the other ones in that patients who have a high antibody titer with the DPPX would be more likely to have dumping symptoms, dumping and diarrhea, whereas with all the others, the motility is generally slowed. And then, as I said, the ANA1 or CRMP are more predictive of cancer. So with the ANA1 or anti-Hu antibody, 30% of patients have symptomatic dysmotility. And in a study where Dr. Lennon followed patients over 2 decades, 80% of them who had this antibody in their serum developed malignancy. So you have to have a high suspicion for malignancy in those patients. This I'm going to skip. So treatment strategies. The treatment, we'd like to gear the treatment towards the underlying cause, and I think that's really the goal going forward. That's what everybody would like. We really are not there yet. We have case studies and case reports, but we don't have a good definitive treatment protocol, so that oftentimes we're left with more symptomatic treatment. So with regards to the use of steroids, there's a variety of case reports. The largest one has only 4 patients, as you can see. There seems to be some trend for improvement, but it's really hard to make predictions. Similarly, there are small case reports about the use of pyridostigmine, octreotide, and peripherally acting opioid antagonists. With regards to immunotherapy, again, the majority of the reports are small case reports. This is the largest case series that I could find, and it was from our group at the Mayo Clinic. and it was a retrospective review where they reviewed the charts. They came up with 23 patients at the end who had evidence of GI dysmotility and had also underwent a trial of immunotherapy. And this is what they found out. 17 patients responded, 6 patients did not respond. Of the 17 patients who responded, out of the 10 who had had transit before and after, 9 out of the 10 had significant improvements in their transit. 1 did not have significant improvements in his transit, but they still considered him a responder because he had been dependent on NG tube suction, and they were able to remove the NG tube. But there are no big differences between these two groups. And again, even though it was 23 patients, it's still a very small study. It's still very hard to come up with definitive information. So, whether or not IVIG reverses the dysmotility, really we need to have a randomized control study, and we need to be able to check scintigraphic studies pre and post. Right now at Mayo, we've talked, a few colleagues and I have talked about the possibility of doing such a study or a clinical trial, and this is kind of the preliminary stuff that we've come up with as far as treatment protocol for 4 weeks with transit and autonomic testing before and after therapy. And the goal would be to maximize reversibility of their dysautonomia and come up with something to maintain their improvement. There have been case reports about the use of Cellcept or azathioprine. Again, very, very small studies. It's hard to know which is more effective and at what dose. So what we're left with is really, at this time, we're left with symptomatic support, which includes diet, nutritional supplementation if necessary. For patients who have a lot of distension and nausea and abdominal discomfort, but their small bowel is working normally, sometimes venting from the stomach can help those people feel a lot more comfortable, and sometimes we vent them from their stomach with a PEG tube and feed them into the jejunum with J-tube, and we would only really consider doing that after a trial of J-tube feedings. Otherwise, we're using a variety of antiemetics, prokinetics, and laxatives. Our prokinetic armamentarium is really, really limited. There are 3 drugs available, and the drugs that are available have really pretty nasty side effects. I've, in my practice, had some luck using cholinesterase inhibitors, and I've used Mestinon at a dose of 30 to 60 milligrams in the liquid formulation 3 times a day in my patients who have dysmotility in the stomach or in the stomach and small bowel. And the previous presenter was right. If somebody has diarrhea, they're not going to tolerate it. But in patients who are constipated, they seem to tolerate it fairly well, and I've had reasonable results, but it's definitely not a cure-all. In the future, endoscopic interventions that might be available. There's people in our group, the therapeutic endoscopists, have worked on doing endoscopic pyloromyotomy in a subset of patients who have pylorospasm. This might be helpful. Also, there is also possibility of obtaining full-thickness gastric biopsies endoscopically and performing an endoscopic suturing technique so that you can get a biopsy, full-thickness biopsy, without sending somebody to surgery. As far as surgery goes, if the patient has symptoms isolated to their stomach, sometimes an emptying procedure can be appropriate. In my 15 years of practice, I've only referred somebody to for that once. Resecting the affected segment is something that's thought of but never really done, because a lot of these people, even though there might be one segment that's more affected, usually it's a diffuse process, and you don't want to keep taking people back for laparotomies and removing their digestive system piecemeal. It's just not a good thing to do. Intestinal transplant is something that I think will be available in the future. There have been a few case series, and people with intestinal pseudoobstruction seem to do just as well as any of the other people who go to intestinal transplant. This slide, I just want to point out to you that emptying is really affected by what the content of the meal is. So as you see, water and low-calorie liquids can empty pretty quickly. High-calorie liquids or homogeneous solids also empty pretty quickly. A low-fat meal in health empties pretty quickly, reasonably well in gastroparesis too. People get into big trouble when you give them high-fat meals. Even in health, that hangs around for a long time. But in the gastroparetic patients, high-fat meals are not well tolerated. And in the next few slides, I talk about the different side effects and such of the various meds, and I'm going to skip over that in the interest of time. So in summary, autoimmune, oops, that's not my summary, there's my summary. Autoimmune gastrointestinal disorders, the frequency, we don't know, but we know that it's probably underestimated. Variable severity, duration, and anatomic extent. Amenable to therapy. Right now we're doing symptomatic things. We'd like to be doing immune modulatory things. In order to do that, I think we're going to have to combine forces so that we have larger case series with standardized protocols so we know what's effective and what's not effective, so that we can treat our patients appropriately moving forward in a scientific and responsible way. And then, I think this is my last slide. Objective testing is crucial to confirm that there's dysmotility. You cannot judge by symptoms. So perform an endoscopy to rule out a mechanical process. Pharmacotherapy can include getting rid of the bad drugs. The drugs that are slowing things down should go. And AGID can often coexist with other immune disorders. It often does. So if you have a patient with a lot of autoimmunity, think about this. Immune therapy looks promising and deserves further investigation. I'll leave you with these final thoughts, and I hope over the last half hour I've inspired you to think more like a gastroenterologist.